Hey, Danny, this is Mark. Can you hear me?
Yes, sir.
Okay, perfect. Okay, we'll get started in about 8 minutes or so. Thank you. Good afternoon, everybody. This is Mark Lim with Healthcare Business Specialist in Chattanooga, Tennessee. We'd like to welcome you to the Rural Health Clinic Billing Webinar Series. This is one of three. These are sponsored by Azalea Health and ChartSpan. And today's date is January the 21st, 2020. We appreciate you guys being with us here today. Here is my picture, my contact information. If you need to get a hold of me, that is the email that I will respond to, and that's my cell phone number. So if you need to text me, you are welcome to do that. Danny Gilbert is here today. She's a CPA and a certified rural health clinic professional with our organization as well. And she will be manning the polls. We have a pre-test that's coming up in a little bit. And so she'll be manning those polls for us, and we'll see how you guys do on the pretest. Louise Burkhead from Trinity Medical Clinic is one of our panelists today, and she will be helping me out with questions. Louise, I know I saw where you're on the line there, so whenever you want to just break in and any comments about anything that we're saying, or if we have questions that you want to help us with, I may send some your way. Even though I've worked with rural health clinics for 30, 35 years now and worked on the billing side of things as far as teaching how the basics of billing goes, I don't bill every single day. So and knowing every single code and all the different modifiers and all that sort of stuff, we like to bring in some help with us on that. So Luis is with us today. Cami Jones will be with us, I think, for the advanced session. Louise will be here with us tomorrow, and if she wants to, she can be here for the advanced session as well. But I do like to get some help with these. If you were with us on the RHC update seminars, those are free now thanks to Azalea and ChartSpan, and they both committed again for 2020. So those are the tentative dates for those. So if you want to save the calendar for 2020, Nashville will be there November 5th. Somerset, Kentucky at the office of the Rural Health Development Center, I believe what it's called. That will be 11/12. And then we'll be somewhere in Alabama. We haven't decided yet if it'll be Clanton or if it'll be somewhere in Birmingham, but that'll be 11/18 of 2020. Looks like we have gone up to the maximum number of people that can be at the webinar at this time. So if you folks that are trying to get in and cannot, your best bet is to use the PDFs that I have sent to you guys earlier with the email, and then phone in. You'll be able to phone in as well. So keep that in mind. I did send that phone number. I was worried we would go over the maximum number of 100, and it's a good problem. We did go over the maximum number, which that is great. We thank you guys for that. Here's what the agenda looked like for last year's seminars for you guys. If you think you are interested in doing that, that was something you can do. What do we do? We prepare Medicare cost reports right now. We're preparing about 170 cost reports coming up. So that will be that will be what we'll be doing for the next three to 4 months. But we do emergency preparedness, program evaluations. We help people start up new RHCs or convert to an RHC. There is a listing of our services in a Google Doc that will explain a little bit more. And if you're in Tennessee, Danny does the TennCare quarterly reports that you are required to fill out as well. So keep that in mind. If you're not a member of our Facebook group, please join our Facebook group. You'll get a lot of information. We're almost at 1,000 members now. I think I checked this a few minutes ago. We were at 986 or somewhere in that range. So there's a lot of people that ask questions, and And it is really a good place to get a lot of information about rural health clinics there. If you do want to, there's another webinar coming up that will be very helpful to you. The National Association of Rural Health Clinics and HRSA is putting together a update on regulatory matters there. Nathan Baugh will be doing that. That will be coming up on January 29th. So put that on your calendar as well. And then we will be doing one on cost reporting in a few in next week as well. That's January the 30th. We're not going to tell you how to prepare a cost report, but we're going to tell you what information we need, or whoever prepares your cost report needs to prepare that cost report timely and accurately. So keep those information sources in mind as we go through, as you plan for the next week or so. Also, questions or comments. If you want to ask a question, there's a little questions mark over here where you can actually type in your questions. We will set aside some time at the end. I think I have about 45 minutes of material. I may run a little bit long, but we have 45 minutes of material. We'll have some time to open up the line so you guys can ask questions after it's over. If you came in on the phone line, I don't think there's a way for you guys to ask questions on that. I'm sorry about that. Disclaimer, everything was up to date as of yesterday when I made up the slides, and I think I worked on a little bit this morning as well. This session is being recorded, so if you have a problem with that, please hang up, and that'll give somebody else more room to get into this webinar. We are going to do something a little different here. I'm not sure how long this will take, but we're going to do a pre-test to see what your knowledge is right now, and maybe see where some of our weaknesses are in this. So, Danny, will you open up the polls for this first question that we have? And so, okay, distributing the poll. Can we get an answer for this one? Rural health clinic status directly impacts payments from the following: A, Medicare; B, Medicaid; C, all payers; or D, Medicare and Medicaid. And we'll see here. We'll stop for a few minutes there, and let's see. Okay, let's close that poll, and then Danny, if you'll give me the answers, that will be awesome.
We had 84% answered Medicare and Medicaid.
Okay, very good, very good. Yeah, that's the right answer. So we had a few of you guys that answered Medicare, 8%, and then the other 8% were all payers. Rural health clinic status only affects Medicare and Medicaid. That's really the only two payers that it will affect. And there's, in theory, additional money for being a rural health clinic from Medicare and Medicaid. Okay, let's open up our second pre-test question here. RHC should charge A, only the RHC reimbursement rate to Medicare and Medicaid; B, all payers using the same charge master; C, all payers using the same charge master except for indigent payments; or D, as much as possible. And so collecting our responses here, and looks like we're going, oh yeah, okay, we're giving a little longer here, a few more. This is like watching popcorn, when they say to watch the popcorn, and when it stops popping, then you get it out. This is what we're doing right now. We're watching popcorn. Okay, let's close the poll on this one right now. And Danny, can you give me the results on this one?
74% said all payers using the same charge from the charge master.
That is the right answer there. You should have the same charge master across the board, charge everybody the same, start with the same number, and then you can make contractual adjustments, or you can make indigent adjustments for people that are indigent. You can adjust that off, but start at the same place as where your charges go. A lot of people, 20% of you answered only the RHC rate or to Medicare and Medicaid. That's not right, and that will cost you a bunch of money. I was at a clinic in West Virginia a few years ago. They were charging Medicare just the Medicare rate, and we figured out they lost between $200,000 and $300,000 a year in lost copays and deductibles from Medicare patients. They're a pretty big clinic, but it's a lot of money if you can collect 20% of your actual charge. And if your actual charge is only that $86.31, a lot of times your 99213 standard charge will be $100. So you're losing just on that one item, $2 or $3 in copays every single time. So RHCs should charge all payers using the same charge master is the answer for that one. Okay, let's move on to the next one. Danny, if you will open up the poll, close that poll and open up the next one. RHCs must have a face-to-face encounter to bill Medicare. And it's filling up quick here. It's filling up quick. Ooh, this one's going to be so close here. It's like a race between the trues and the falses at this point. So this one must have been a pretty tricky question.
I think.
Okay, Danny, you want to close that one out and then give me the official answer?
54% true and 46% false.
Yeah, this one was tricky, and the answer, this one is false. And the reason why it's false, and I put the answers in the pretest there with an explanation of what when something was false, I put an explanation of the answer. It's false. You can do chronic care management services, that G0551 code. You can do that without a face-to-face encounter. So keep that in mind. Everything else has to have a face-to-face encounter from a physician, nurse practitioner, PA, and the patient. But the exception, and it seems like there's always exceptions to Medicare rules. Anytime I say all, it's usually never all because there's an exception to that. So in this case, chronic care management services, you could bill that to Medicare. Medicare, actually, I think the rate used to be $67.03, and now it has dropped down to $66 and like 93 cents or something like that for 2020. It's the first time I've seen one actually drop in a long time. So let's go ahead and get through the questions here. Next question, Danny, if you'll open up this poll. RHCs bill Medicare RHC claims for RHC covered services using the following claim form: a 1500 or a UB04. And so which claim form are we going to use? The UB04 is what we call an ANSI 837I, and the 1500 is what we call an ANSI 1500P. P stands for professional, I stands for institutional. And okay, Danny, what's our results on this one? Looks like we did a lot better.
It's a UB04.
93%, that is right, absolutely. So we did much better on that one. We all know we use the UB04 form. Okay, next one. An RHC must include a CG modifier on all claims for RHC covered services. Is that true or is that false? An RHC must include a CG modifier on all claims for RHC covered services. And this one is pretty tight as well. Some of you guys are pretty smart here.
Actually.
Okay, here we go. And let's close that one out, Danny. And what do we have?
You had 48% true and 52% false.
And the falses were correct. You do not have to put a CG modifier on an IPPE and the chronic care management services. Those do not require a CG modifier. Those are the only two services that I know of that do not require. If you submit a claim, you're going to have at least one line item with a CG modifier. But the IPPE, which is the initial, that's like the welcome to Medicare, not really a physical, but it's that initial welcome to Medicare visit does not require an IPPE. It requires a CG modifier. If you do put the CG modifier on there, then the claim will probably process, but it's not required. Okay, the MSP payer questionnaire. Questions must be asked: A, every visit, B, annually, or C, every 90 days. And if Danny will open up that poll there, looks like it's opened up. And we're getting a variety of answers here. Wow, you guys are doing good on your vote percentages too. We're up to 80 something, 85% voted. Okay. Let's close that out real quick. And Danny, if you give me the right the answers that people gave.
Yep, 69% for every visit and 21% annually.
Okay. The right answer is every visit. That's the reason why I put this question on there, because a lot of you guys don't realize that every single visit, there's a listing of about 8 questions that you need to ask your Medicare patient. Medicare saves about $10 billion a year in finding somebody else to pay for that health claim, primary instead of Medicare paying it. So you're required to ask a certain number of questions. You're not required to give them that form and make them sign it every single visit, but you are required to ask them those questions, and you're required to document that you've asked them those questions every single visit. I know that's a lot hard for a lot of us to swallow, but that's what the rules are. And occasionally they will do MSP audits, and a lot of people get in trouble for those. Okay, the following are not RHC covered services. And when I say RHC covered services, I mean under the RHC benefit, these were not covered under that benefit. So A, lab test, except the venipuncture. B, technical components. C, hospital services. Or D, all of the above. And we'll wait a few minutes here so we can get, we typically wait till about 80% of you guys vote, and then we'll go from there. 77% voted, 80%. Let's go ahead and close it out, and so we can move on. And Danny, what's our numbers?
83% said all the above.
83% of you guys said all of them, and that is the right answer. None of these services are covered under the RHC benefit. Typically, if you're an independent RHC, you're going to bill these things on a 1500 form, and you're going to use your MPI number that is being credentialed with Medicare Part B. Fee for service would be the MPI number that you would use for those. If you're a hospital, then you're going to be billing that on the hospital's MPI number, your outpatient MPI number, and you're going to, most of these, you would use a UBO, most of these services, you'd use a UBO4 form. You'd use a different bill type. It's going to be a 131 bill type or a 141 bill type, while hospital services, for the most part, are going to be billed on the 1500 form. I think if you're an option 2 provider-based hospital, then there may be another way they bill that one, but I don't remember it off the top of my head. But that's important for you to remember. Let's go on here.
Yeah.
And
yeah, all of them. Yeah.
And I don't know where we're getting feedback. Danny, do you know where we're getting feedback from?
I don't see anybody's line, so I'm not sure.
Yeah, I'm not sure where we're getting the feedback. I know Luisa's, her line is muted, self-muted, so I'm not sure where we're getting feedback. But if you're talking, please don't talk, or try to make sure, just check your phone lines and make sure that you have those self-muted, if you don't mind. CPT2 category codes cannot be included on the UBO4. Cannot be included on the UBO4. And we're voting is going pretty good here. We're 50% voted. And this testing is taking longer than I anticipated, so I probably will have more than 45 minutes of material here. Okay, we're at 73% voted. Let's go ahead and close it out here, because we're going to have to keep moving here. And Danny, what was our answer?
59% true and 41% false.
The trues have it. Those quality indicators, HCPCS codes, those category 2s cannot be included on the UBO4. If you want to get credit for those, there's ways where I think you can put them on a 1500 form and bill them out that way. You won't get paid anything for it, but you'll get your numbers. You'll get your quality indicators there. The best way is to get with some type of registry and report those numbers to the registry. There was just a MedLearn Matters the other day that came out that listed all the registries in an Excel spreadsheet. And so I would look at that MedLearn Matters, and we'll talk about that when we go into the advanced session on how to report those and how to get your hands on that registry as well. But that's important, especially if you're a member of an ACO or an insurance company. Some of your commercial insurance companies will pay you additional money for those codes as well. So you'll make sure you're getting those in. In most cases, Medicare allows an RHC to collect A, the Medicare allowable copay from the fee schedule, B, the CO45 reason code amount or contractual adjustment, D, the 20% of reasonable charges from the patient. And I think I told you guys that answer when I was answering something else a few minutes ago. But let's see here, Danny, we're on 59% votes and 72% votes. Let's go ahead and close it out now. So, and Danny, will you give us our answer?
83% said 20% of the reasonable charges from the patient.
Okay, that is the right answer. It's 20% of charges from the patient. There's no limiting charges in rural health clinics. You're not this Medicare allowable from the Medicare fee schedule. It's not like Medicare Part B fee for service. It's whatever's if you have a reasonable charge. And I've seen, I was at a clinic last week, 4 clinics last week in Kansas, and their charge for a 99213 was $210. They were collecting a $42 copay on every 99213. So in that case, that would have been, that's perfectly acceptable. We could collect the whole $42 from them. If it would have been Medicare fee for service, Medicare would have allowed that clinic to collect about a $13, maybe $14, maybe $15 copay from the patient. So that's one of the disadvantages to patients, is that in a rural health clinic, they actually pay a little bit more by coming to an RHC. So you have to be careful with your charges, not to charge too much for your 99213s, 99214s, because that will dissuade your Medicare patients, especially from coming, because they're on a fixed income, as they will well tell you. Number 10, negative reimbursement refers to the following. This is like a horrible thing already. Receiving more than the RHC charges from Medicare. B, Medicare recouping money from the RHC due to the deductible at the beginning of the year. C, the difference between what the Medicare fee schedule would have paid you versus what the Medicare RHC reimbursement pays you. Okay, and Danny's got the poll open, and let's see how we're doing here. And this one, moving, we're at 73% voted, 77% voted. All right, Danny, close that one out. And what did we get on the answers from this one, Danny?
Yep, 67% said Medicare recouping money from the RHC due to the deductible.
And that is the right answer. It's a horrible answer, but that's exactly what Medicare does. This is the time of year when, if you have Medicare claims, you may want to hold them until March or April and then release them, because whoever eats that deductible is the one that has to pay that back. And this year, the Medicare deductible has gone up to $198. And if you're an independent RHC, your capped rate is $86.31. That's a $112 difference. So if you see a Medicare patient on January the 1st and you charge, like this clinic in Kansas did, $210 for a 99213, when you submit that claim to Medicare, you're not going to get paid any money, but they're actually going to withhold from you 198 minus 86. If it was an independent RHC, they're going to withhold $112 from you. So that's negative reimbursement is a bad thing. These other two are bad, but actually the first one is pretty nice. You can actually receive more money from Medicare than what you charge. There's no lesser cost of charges from Medicare for a rural health clinic. So keep that in mind. That is something that you can actually collect more. It's called a negative contractual in that case. Number 11, influenza and pneumococcal shots in a rural health clinic are A, paid using a log on the RHC cost report. B, billed on a 1500 form. C, billed on a UBO4 form incident to an encounter. Or D, billed to Medicare Part D. There's something called Medicare Transact RX, and that is that is something that some people use for certain immunizations like shingles. Danny, if you'll we're at 80%, so let's close out our poll here. And wow, 99% of you guys said put that on the cost report. So that's awesome, you guys. All these cost reporting webinars, you guys must have been paying attention to that. So absolutely. So that's the right answer there. So I don't think we need to talk a whole lot about that because you guys have that one down pat. Finally, this is the last question that we have, number 12 on our pretest, is RHC services may be billed incident to RA, venipuncture, that's a 36415. B, shot administration, I think that's a 96372, if I remember that HCPCS code right. And then drugs that cannot be self-administered. And finally, D, all of the above. And we'll wait a few more minutes here. We're at 50% voted. And let's see here. And you guys know this one pretty well too. Okay. And just a minute or two more. Come on, let's get the 80% voted. And 76, 77. Y'all taking longer on this one than the other one. 78. And let's just go ahead and close her down because we got to move on here. And Danny, what's our answer?
86% said D, all of the above.
And that is the correct answer. So you guys, y'all should be teaching this class instead of me. You guys know it very well. So D, all of the above, all of these can be billed incident to. Incident to, basically, if there's that can occur, incident to can occur on the day of a visit. If I go and see the doctor and I get maybe I've got a cold like I have right now and I'm coughing, maybe they'll give me a shot of Rocephin. So and then maybe they want to draw blood and do a blood test on me. All three of those items could be billed incident to. The clinic will not get any more money. It's a bundled payment, but you want to charge for it because you get 20% of the charge for these incident to items if you bundle that into the CG modifier line on the UBO4 bill. So we'll talk more about that when we get to that point in our webinar here. This was our pre-test here. I think you guys did really well on that. Before we move on to the actual webinar piece of this, Danny, Louise, do you have anything to say on the questions that we asked and any of the answers that we gave, as far as either I was a little bit wrong or if you have some more to add to it?
You are absolutely correct on all of them. The one thing I would like to point out on that face-to-face encounter one, the IPPE does not require it, but the annual wellness and the subsequent wellness does require it.
It does now. Louise, I can tell you, if you're in a rural health clinic, you have to have a face-to-face encounter even with the IPPE. It is a requirement. That is even.
I'm sorry, the CG modifier one.
The CG modifier requires you for the IPPE.
No, the IPPE does not require the CG modifier, but the annual wellness.
Right. Oh, right. Okay. Got you.
Yes.
Yeah. That makes sense. Yeah, that's right. The IPPE, the Welcome to Medicare, the one does not require the CG modifier, but the annual wellness exam that when you do the IPPE, when you first the Welcome to Medicare, and then after that you'll do an annual wellness exam. Those require a CG modifier. That's right, Louise. That's absolutely right.
Correct.
Okay. And then Danny, we have some questions there. Do you think those questions we can wait till the end, or is there something that needs to be?
Somebody was answering the polls in the question box if there's no questions.
Okay, gotcha. Okay, perfect. Yep. Okay. And then where are you going to find a lot of this information that we're talking about? Our website is, and you can tell how long I've been around. Our website is ruralhealthclinic.com. And so if you go to our website on this RHC billing, we will post this webinar will be there. The pre-test will be there, so which will be a good learning tool for new billing people that you guys have. All the PDF will be here. Normally, I put this in the handout section over here for you guys, so you can get your hands on it here. But for some reason, GoToWebinar was angry with me today, will not let me drop any files in here. So this will be on our Rural Health Clinic billing, ruralhealthclinic.com RHC billing website this afternoon. I will post that to it. I'll also post our presentation. Here's what it looks like right now. And if you see something like that, you're in the right place. And we will have all these recordings, especially for these people that can't get in. We got a lot of people trying to get in, which is great, but we appreciate it very much. And then here's some of the things that are in there. There's some policies and procedures on how to bill RHC services there that are on this website as well. So you can take a look at those. The PDF, all of these are hot links. So you can actually, anytime there's an underline under this, if you just click on it, you're going to go to a big document here. We have a lot of people that are brand new to the RHC program. And once you become certified as a rural health clinic, there's a lot more steps for you to actually get paid that are sort of administrative, like getting your CCN number, getting your rate set, enrolling in Medicaid. And so for you guys that are in any of these states here, we put together a little report here. So we always called it that time, we call that the valley of despair. You've become a rural health clinic, you think you're going to get paid, and you ain't going to get paid for another 3 or 4 months. So we've sort of outlined the valley of despair, and we go over it in a webinar with our clients once they pass the inspection to let them know what's going to happen there. So if you guys are new to RHC, that you've just been surveyed, that is a really good document to go through. There's our first question there. RHC status only affects reimbursement from Medicare and Medicaid. We always tell people, follow the golden rule. He who has the gold makes the rules. So, and this is what's so hard about billing medical practices in general, is everybody has different rules. It'd be like playing a game of basketball that everybody has different rules depending on who you're playing with. That's exactly the way billing is for physician practices these days. Blue Cross and Blue Shield of Tennessee has one rule, Cigna has another, Aetna has another. What you can do is make sure you charge everybody the same using the same charge master. Don't have different charge masters for Blue Cross of Tennessee, and then one for Aetna, one for Medicare, one for Medicaid. Start from the same place, and then contractual adjustment right off the difference on what you receive in payments, and then bill according to everybody's rules. And that's hard to do. I mean, a lot of times you want to separate your billers by company. So you may have a Medicare biller, you may have a Blue Cross of Tennessee biller, you may have an Aetna biller, and you may have a TennCare Medicaid biller. But that way they have to learn less rules. Instead of dividing it up by alphabet, divide it up by by insurance company. And that will help people. Here's some of the reference materials. I didn't just make this stuff up. I actually looked up stuff from Medicare, from the Centers for Medicare and Medicaid Services, that's called CMS. They do put out these great fact sheets. And so there's an 8-page fact sheet. So if you're brand new to the RHC program, you can go in and look at this beautiful 8-pager that has nice little pretty pictures in it, and it will explain to you some of the basics of rural health clinics. Also, CMS has something called the Rural Health Clinics Center. It is a website where they put a lot of information. They haven't really been active in the last year. This spotlight has not changed basically since last year. So we've had the same spotlight now for a year and a half. They haven't really changed a whole lot. I used to check it about every 2 weeks, and I quit checking it every 2 weeks because there really wasn't that much changing in it. But here's the link, the hot link to it. But if you go down, it's actually about 6 pages of information, and there's very good information in here. There's the payment rate increase from a cost report standpoint. Chapter 13 just changed, but that'll be on the next slide. I'll show you that. And here's something that's changed in the last year or so. The Medicare listing of certified RHCs, there's something called, that goes to a link called QCore. And in Q-Core, you can find out all of the RHCs that are active in your particular area. You can also find all the deficiencies that everybody got, and you can sort it out by state and see what the state inspectors are looking for. I can tell you, emergency preparedness, a lot of people don't have their emergency preparedness plans up to date, and program evaluations. Those are two condition level deficiencies, and you'll see that's probably the highest two that we see on most of the list. So you want to take a look at that and see see what deficiencies are being sought after. Here's the newly revised Chapter 13. This actually just changed either yesterday or the day before, because I looked for this a couple of days ago, and it was from the old 2018 date. So this just changed. They added about 5 or 6 new things to this. They're in red. Notice how up here where it says table of contents and it's the revision 263-12-2019, stuff that was in red as you go through here, those are changes. They made 5 different changes to it. We'll go over what those 5 changes are as we get more and more through this webinar series. So some of the other useful links here, Chapter 9. If you don't have any clue how to do a UBO4 for a rural health clinic, this is the place to go. You can, and we have a little cheat sheet that we're going to show you. When we get further in the webinar, we're going to show you our little cheat sheet on, I think there was something, what was it called? 5100 format. It was 2012 when it changed, but there's a 5100 format that everything changed to, and it hasn't changed since. There's 81 form locators. And there's all sorts of different little numbers that you can use that mean certain things. If you want to look up what those numbers mean, you go into Chapter 9, and that will tell you how to fill that out. And we'll give you that cheat sheet as well on how to fill out the UBO4 as well. And then Chapter 15, preventive services. A lot of you guys aren't doing all those preventive services at Medicare. It started about 2011, 2012 in the Obama administration, where there's about 17 different preventive services that there's no copay from the patient. There's no deductible for the patient. They're absolutely free for the patient. And they can actually, a lot of them, Medicare will pay you as an RHC visit. So if your visits are low, look at Chapter 15, look at those listings of services that you can provide as preventive services, and look at those. That's a great place to start. And then laboratory, Chapter 16, your laboratory, and from most cases, it's going to be billed to Medicare Part B, and you're going to get paid fee for service for that. If you're a critical access hospital, you'll get paid cost for it. But for the most part, you're going to be using Chapter 16 for look up your answers to laboratory service. In fact, somebody asked me a question about lab just last week, and I was reading Chapter 16, trying to find out the answer to it. Still didn't get a good answer, but that's the resource that you want to go to for that. This one here. This website is great. This is from Noridian. Don't worry that Noridian is not your MAC. It is a Medicare MAC, and Medicare is the same throughout the country. And what I love about this one is it's set up in a table format. I'm a CPA, so I'm used to sort of tables and numbers and organized information. There's about 6 pages of these little tables, and they have things that you need as far as an RHC, as far as billing goes. So that is a great resource. Again, don't worry that you're not Noridian. If you have Palmetto or CGS, this will work perfectly fine because it is Medicare. So keep that in mind. And then other resources as we go through this thing, the National Association of Rural Health Clinics, they're having their one of their 2 annual meetings on March the 18th through March the 20th. That's in San Antonio. I highly recommend going to that. There was Charles James gave an excellent billing presentation last year on Medicare secondary payer, one of the best ones I think I've ever seen. I will be stealing a lot of that when we do our Medicare secondary payer piece to this, because I was working on this presentation last night. I'm like, wow, Charles did a really good job on this. So there's a lot of good presentations at the National Association of Rural Health Clinics, and so we definitely recommend that you join. Even if you don't join, the listserv is completely free, and the technical assistance is perfectly free as well. And there's a lot of billing information on here. This is the rural assistance from HRSA, the RHI hub, the Rural Health Clinic Information Hub. there is a lot of great information on here. And there's some couple presentations that were done on billing. So if you got new people that don't know how to bill, or if you're taking a long drive, you got to go to Disney World like I had to do the other day, you can, I'll flip on one of these audio recordings of this and listen to that. I know my life is sad, but that's what you do if you want to learn about RHCs and about RHC billing there. And we did a, let's see, mine doesn't show up on here, but we did one for them last summer's in July on cost reporting. So there, we have a session on cost reporting in this particular section as well. If you want to become a certified rural health clinic professional, I highly recommend it. I went through the process last year. Danny went through it the year before. There is the link. The courses are opening right now, and you guys can take the test on March the 18th and March the 20th as well. And then Arch Pro Coding. This is another one. This is Gary Lucas and John Beard. They do a great job. They have a certification for you to become a certified rural health coder. It's a pretty intensive thing. I haven't gone through it yet, even though I've got a ticket to go to it. They're not going to charge me anything for it, which is great. I just have not had the time to go through it yet. So keep that in mind. That is something that you want to do. Acronyms. We have a ton of acronyms, and I'll go through these very quickly. All-inclusive rate. If I say AIR, that means you're going to get your all-inclusive rate. For independent RHCs, it's typically the cap, which is it's 86.31 now. If you're provider-based RHC, it could be the average payment per visit is about $207 a visit. So it can be any number, and it will go up or down. When I say CMS, Centers for Medicare and Medicaid Services, when we talk about RHC, we're talking about a certification as a rural health clinic by Medicare. You have to pass an inspection by the state or by Quad A or by the compliance team in order to be a certified rural health clinic. There's only about 4,500 in the country. So make sure you guys, we're talking about being a certified rural health clinic, not just a clinic that's in a rural area. A lot of vendors get that confused, and you tell them you're a rural health clinic and they say, excuse me, they say, yes, we can service you, we can do everything, and they can only do a 1,500 form. So that's why we trust Azalea. Azalea's really, you know, the rural market and the RHC market, those guys have been working super hard to provide a fantastic service in rural areas. So that's why we promote and work with Azalea. They're very good. And there's other good ones too, but that's the one that we feel the most comfortable with at this point. Medicare Administrative Contractor, that's what we call a MAC. That's going to be Palmetto. That's going to be CGS. That's going to be Novitas that we just saw. And then MedLearn Matters. Those Medicare sends out transmittals in something called MedLearn Matters. So you want to make sure that you bookmark that page and you get those as well. Some of these, I'm not going to go through all of these, but you can reference those later because we're going to run out of time here. PTAN, you are going to be required to get a PTAN number from Medicare. Actually, they call it a CCN number. I'm about to change my slide because I just think, wait a minute, it's not really a PTN number from Part A. From Part A, you get what's called a CCN number. From Part B, you get a PTAN number. So even my slides are wrong. This is complicated stuff here, but you'll get a CCN number from Medicare, and you have to have that number even though you never use that number for billing on the UB04. That CCN number actually will link to an MPI number. You will have to have a group MPI number. That's a 9-digit number. And to be a rural health clinic, you have to have a group number. Don't have an individual number. Some of you guys, if you certified as a rural health clinic many, many years ago, they would let you have an individual MPI number. If you have an individual MPI number now, if the physician dies or the owner of it dies, that rural health clinic goes away. If you have a group MPI number, then that rural health clinic can be sold or can be moved on to somebody else. So that's why you want that group MPI number. And typically they made most people get rid of those. In some states, like if you're in Alabama, they will not let you register with Medicaid if you have an individual number as well as a rural health clinic. So keep that in mind. I mentioned ANSI 837I institutional format. That's what we use as rural health clinics to bill Medicare on the UBO4. And for professional claims, that's an ANSI 837P. That's the 1500 form. Medicare, your non-RHC services, most of those will be billed on the 1500 form if you're an independent RHC. Also, Medicaid in each state, do they use a UBO4 or do they use a 1500? It depends on what state you're in. I know South Carolina, they use a 1500 form. Alabama uses a 1500 form. I'm trying to remember. Arkansas, I think, uses UBO4. So depending on what state you're in, you need to look up that to see how to bill as a rural health clinic. Here is the revenue cycle. This is something that Azalea said, and this is why billing and collecting money is probably the most complicated process in healthcare than I think I've ever seen. And so here is the revenue cycle that we go through in the 3 hours that we have. We will not be able to get through all of the different cycles that you have to go through in order to get paid as a rural health clinic. We cover sort of the high points with these webinars, but do remember your revenue cycle has to be complete, because any one of these little blocks here, if you don't do correctly, you're going to get denials, you're going to get claims rejected, and you're not going to get paid. What's confusing about this is the RHC services, Medicare Part A and Medicare Part B. The problem is your claims are paid through Medicare Part A on a UBO4. That's because you have a cost report, and it's sort of like a hospital. But another piece of the problem is the patients, they have to have Medicare Part B. They have to have Medicare Part B in order to get paid. They get all the benefits of Medicare Part B. So you have one piece of reimbursement has to do with Medicare Part B, what the coverage is, while the payment comes through Medicare Part A. And it's very confusing on where Medicare Part A and Medicare Part B come together. I think like when Louise was telling me about and I was confused on what she told me. I thought she was telling me that to get an IPPE in a rural health clinic, you did not have to, and here's, I think I got a slide on it right here. For example, pay for an annual wellness exam, a rural health clinic must have a physician, PA, nurse practitioner have a face-to-face visit, while for Medicare Part B, a nurse only is required to bill for that service. So those rules sort of cross-sect, it's very, very confusing. And that's why there's 100 people trying to get in on this webinar today, is to figure out the different things that are going on. And I think the whatchamacallit took a little bit longer than I thought. The questionnaire that we gave you, the pre-test. So I'm at 3:47 right now. We have about 13 minutes left in our time. Why don't I stop here, and then we'll pick up tomorrow. And if we have to, we'll just add another 45-minute session to this. We'll have 4 sessions instead of 3, because the pre-test took a little bit longer than what I thought. If you have questions, now's a good time to either type in your questions, or you can raise your hand and we'll open up the line so you can ask us questions. And Louise, do you have anything while we're sort of sorting this thing out that you want to add to what we've talked about so far today?
I would say on the certification, I did go through Gary Lucas' class, and he is very informative, and you do learn an awful lot when it comes to billing, coding, the rules and regulation. He covers the whole aspect of it.
Okay, I need to do that. I won that at the RHC, the Kentucky RHC Summit 2 years ago. I won a ticket to his coding class, and it's worth $900. I still have not used that thing yet. So I keep trying to talk. Either myself or Danny is going to take that course. So I think that's really good. Let's see here. And Danny, do you have? Let me see here. Do we have any lines that are open, or do you have any questions?
We have one question. It's from Anita. It says, on the UBO4, can we put the B12 injection fee with the office visit?
The answer, and Louise, you can help me with I'll give Louise, I'll give my answer to Anita, and then Louise, you can correct me if I'm wrong. If you do the problem with B12 injections is it has to be medically necessary, and a lot of times they're not medically necessary. I think there's a certain diagnosis with fatigue. I forget what the technical term is. If you have that diagnosis, then you can get a B12 shot, and you could put that on there, and you could pay, I guess, an injection fee as well. The problem is probably 99% of them are going to be not meet the criteria to be paid, and you'd probably need to give them an ABN that says it's a non-covered service, and then just collect money from them. Louise, is that your answer, or is there something different I'm missing?
You're correct. There's 2 codes, and I know one of them is pernicious anemia, and the other one's vitamin B12 deficiency. Fatigue will not be a medical necessary. Only those 2, as far as I know. There may be some more, like with cancer and stuff, that you could use. What I do is the ones that are medically necessary and they come in within that 30-day window, then we bill it with face-to-face. Otherwise, it's recorded on the cost report as a incident 2 that we didn't have a face-to-face to bill it.
Okay. All right. Very good. Very good. Okay. Danny, do you have any other questions for us?
That's the only ones that have come through.
None have come
Oh,
through.
this came through. I'm sorry. Which RHC certification do you recommend?
Which one do we recommend? I recommend both. I would absolutely do both, because from my standpoint, I know what the RHC certification is like, and it was very helpful to me. I learned a lot of being around RHCs for 35 years. I know a lot already, but there are areas that I'm weak in. You know, I'm weak in billing, weak in management, as far as like human resources and stuff like that. And so I thought that was very good for me. And Louise has done the Gary's thing, and you can tell us more about it, Louise. But I mean, from what I've seen, it looks amazing. I've heard Gary speak several times at meetings, and oh my goodness, he is so good.
He is. The only reason I haven't done the NARHC one is the on-site testing at the conference. I just don't have time to take the conference every year.
Yeah, and Louise, that's absolutely right. The problem with the NARHC one is you have to do an on-site test, and every year you have to go to at least one of those conferences. And those are, like I said, I've been to every single one except for the last one I didn't go to, and this one I'm not going to go to because of my daughter coming home from college and my little nieces coming in. They all come in during spring break, so I'm not going to go to this one. You have to go at least one per year. That's super expensive, those conferences, and that's a lot of reason why we do what we do on our little seminars. We take the information that we learn from those conferences and bring it closer to you guys, so that you don't have to get an airfare to Phoenix, Arizona, and you don't have to spend 3 or 4 nights in a $200 or $300 a night hotel. So the expense of the NARHC would be much more to keep up than the coding one. I think the coding one would be very, very specific on your billing services as well, which that would be very helpful. Okay. Danny, did anybody else questioning?
Yeah, we've got a couple more that just came in.
Okay.
What are the 8 questions that we need to ask at every visit for Medicare secondary payer?
Do you have black lung? Is it? We'll go over that when we go over the Medicare secondary payer. But off the top of my head, I know the first one is always, do you have black lung? Which is nobody in Tennessee does. If you're in West Virginia, you would. And then, are you employed? And then I think it's the group health. Is it 20 or less employees? And then if you're active, there's 100 or more or less employees. There's another category there. Was it an accident? What they're looking for is, did you have a car wreck? Did you fall down at Walmart? That's the question. And if you actually, there's a questionnaire. It's a horrible questionnaire. It's about anywhere between 16 and 30 pages long. I don't remember which one it is. If you actually printed that thing off and gave that to them, it would not work. You can condense it into 8 very quick questions. Louise, You got anything on that MSP? Do y'all give them? What do y'all do to take care of that?
Well, what we do is annually we have them go ahead and sign off on it. And then every visit we review the same, I think it's like 5 or 6 questions, like you said. And if they answer yes to any of them, then we go ahead. In our chart note, we actually have it hard coded in. MSP has been asked and verified today. You can also, we go on e-services and check eligibility through there, and it will tell you if they have any MSP on file.
Yeah, so yeah, because a lot of times if especially if they have like a car accident or something like that, there's a period of time where Medicare is going to be secondary. You know, State Farm or Farm Bureau or whoever it is going to be covering their medical expenses, and that's going to be primary. So in those situations, you can look up to see about that.
We have a few that like had a workers' comp case and they settled, but they didn't settle, and so it's an ongoing thing. If you use that particular diagnosis 10 years down the road, they're going to throw it out for a workers' comp case, and you're going to have to file it.
Okay, very good, very good.
Mark, one thing I was going to add, Anita, I'll send it to you, and if anybody else wants it, we actually have a questionnaire form. It's just a 1-page that has all the yes or no questions. And then if they answer yes, it has the additional information that you have to collect that I can send out if they want to shoot me. Whoever needs it, they can shoot me an email. And Anita, I think you're the one that asked the question, so I can go ahead and email that to you.
Yeah, and Danny, if you'll make sure you send that to me, I'll make sure I put it in our slide presentation when we get to the MSP section. Because the rate we're going, we may have 5 of these webinars, but that's okay. We're, you know, as long as you guys are getting this stuff, and we're recording it, so you guys can have it and it'll be up to date for at least a few days anyway, until Medicare changes something on us. Danny, do you have another question on there?
Yeah, there's a few more. This one's for provider-based. They bill x-rays through their hospital. You also bill radiology services for Medicare Advantage plans through the hospital.
And that was one of our slides on this one that we did not get to. Medicare Advantage is just like commercial insurance. So they don't really follow the Medicare RHC rules. They sort of have their own rules. What you can do, though, is you can negotiate with them, and some of them, and I never fully understood, some of the Medicare Advantage plans are very, very willing to pay you the RHC rate. I think they're a different type of Medicare Advantage plan, and they get incentives in order to contract with RHCs. That's the reason why I would think they would do this. But they will pay you your RHC rate. But what you want to do when you're dealing with Medicare Advantage plans is what you negotiate is what you get paid with them. Louise, how do y'all deal with Medicare Advantage plans?
In Tennessee, the only one that we have had the issue with was Amerigroup Advantage, and they did require us to go in as an RHC, and the payment is reduced to the heir, and you know, so you do lose money there. But the rest of them, and I think it all depends on your taxonomy code with your NPI, which we have both listed in the NPPES.
Yeah. And Louise says it's something that you would not think, but if you're an independent RHC, most times you're better off not getting your RHC rate, because your AIR is actually lower than what you would get paid fee for service. So a lot of times when those Medicare Advantage plans say, we're going to pay you the Medicare fee schedule, you're like, throw me in the briar patch. Thank you. We'll take the fee for service. And we have some clinics that, you know, when they have that Medicare open enrollment period of time, is they'll have the Medicare Advantage people come into the waiting room and try to get people on the Medicare Advantage plans. Now, these are independent RHCs. If you're provider-based, you will no doubt get a higher rate being a provider-based RHC than you would from the Medicare MCO fee for service. But for you independent guys, the Medicare Advantage plan is actually a really good thing. You want to try to get as much Medicare Advantage as you can. In most cases, you can't You can't say that in every single case, but in most cases, that is the rule there. Okay, Danny, do we have more? You said we have some more questions?
Yep. Elena asked, Medicare annual visit done by the nurse only. I don't really know what she's asking, but that's what it says.
Yeah, and Louise, you can correct me on this. My understanding when I read that, when I read the rules, it says that as a rural health clinic, you have to have a face-to-face encounter with that. If you're a private practice, Medicare Part B, fee for service, a nurse only can do an annual wellness exam. I'm not sure if she can do an IPP or not, but we've had this question a lot, and every time I've looked it up, it's always said as a rural health clinic, you still have that face-to-face encounter where we have a physician, nurse practitioner, or PA have a face-to-face with that patient. Is that your understanding?
Yes, that is correct. When I stated that a while ago, I was confused and answered 3 and 4 on your pretest.
Yeah.
I'm sorry, 3 and 5. The CG modifier has to be on the GO438 and GO439. On the IPPE, which I think is GO402, that one does not require the CG modifier, but they all require face-to-face, yes.
Yeah, okay, that's what I thought. So, and one thing too, one thing that's weird about the IPPE, while we're talking about it, is that is the only one of those preventive services where you can actually have 2 visits in one day. So if I come in and I see Louise, she's my provider, and I'm brand new to Medicare, I do my IPPE, and I've got this cold here that I've been fighting now for 2 weeks, it won't go away, and I see them for that as well. That is 2 visits. You get 2 all-inclusive rates from Medicare in that case. Now, go forward 1 more year and I come back and I do my annual wellness exam. So I get my annual wellness exam done and I still got my cold. That's going to be 1 visit. So IPPE is the only one where you can actually have 2 visits in one day, where you actually get paid 2 visits in one day. Okay, Danny, you got another question before we're right above the hour here, so.
That's all that we have, and then the one hand we have was Betty Kay, and she actually typed her question in, so I think we've answered that.
Okay, perfect. Okay, well, Louise, thank you so much. You have been super helpful today. We will pick up tomorrow right where we left off today, and we didn't get as far along as I thought we would. I think the pretest sort of slowed us down a little bit, but hopefully I think you guys think that's helpful, and that will give you something you guys can use to help train people down the road as well. We'll have that in our I think if you guys signed up early enough, I sent it to you this morning, and then that will be on our website as well. So thank you guys. We will see you guys same time tomorrow. Yes, Danny.
One quick thing, and I think Louise had mentioned it. Somebody had asked what the website was to check the MSP stuff.
To check the MSP?
I think Louise mentioned that it was possible. But
in Tennessee, we're under the Palmetto GBA, and they have what's called e-services. It's a free, you have to sign up for it. You have to log in like every 30 days or sooner. But you can check claim statuses. You can upload your quarterly credit balance reports. You can check for the MBI if they haven't got their new card. And you can also check claim statuses, and it's all free service.
Yeah, and there is a website that when I looked at Charles James' presentation from last March, that he had a website to go check that as well. So I will, when we do the Medicare secondary payer piece to these webinars, we will have that. We'll have that link in there for you guys then. Okay. All right, Danny, we got any more before we close her down?
Yep, that's it.
Okay. All right. Well, same time, same channel tomorrow, 3 p.m. Eastern. Thank you guys very much. We will talk to you guys tomorrow.